Hi, and thank you for joining me for this presentation entitled Contraception and Hormone Therapy, Putting the Risk of Venous Thromboembolism into Perspective. One of the reasons I wanted to provide this presentation is because I work in a family medicine clinic where I'm often asked by doctors or patients about the appropriate use of contraceptives or hormone therapy. I imagine that you either get asked by doctors or patients as well, and specifically maybe get asked about the risk of venous thromboembolic events from time to time. Perhaps you have a patient that has even experienced a DVT or a PE while taking contraceptives or hormone therapy. I hope that you'll find that this presentation will provide some clarification for you and your patients. I also hope that you'll find this presentation to be interesting because I've decided to create a debate format to go through these issues, in that I'll be using pro and con sides to determine whether or not there is a real risk for venous thromboembolism with these therapies. For this presentation, I do not have any actual or potential conflicts of interest. However, I do want to let you know that I may be discussing off-label use of medications, especially when we talk about non-hormonal treatments for symptoms of menopause. The learning objectives of this program are as follows. First, we're going to describe the mechanism for which venous thromboembolism or VTE occurs with estrogen-containing medications. Then we're going to shift to looking more into combined hormonal contraceptives and comparing and contrasting the various components of these agents and their potential risk for VTE. Then we'll be interpreting current evidence that evaluates VTE risk for various contraceptives, and then shifting into hormone therapy, looking at the evidence there, so evaluating clinical trials that indicate an increased risk of VTE in women choosing hormone therapy. Throughout the presentation, we'll be going through a couple different specific patient cases, and from that, we're going to determine the risks and benefits of using an estrogen-containing agent. In addition to the learning objectives that I have created, I would like you to take a few seconds to think about, or maybe even write down, your own personal learning objectives to describe what you would like to learn by the end of this presentation. Perhaps you can think about why you signed up for this particular CE and what you hope to learn for implementation into your practice. Let's begin by talking about the risk of venous thromboembolism, or VTE, with combined hormonal contraception. Keep in mind that when I am talking about VTE, that term really encompasses both deep vein thrombosis, or DVT, and pulmonary embolism, or PE. The way that I'm going to present this part of the presentation is as follows. We'll first go through a brief patient case, and then we'll have a discussion about the proposed mechanism of action as to how VTE is caused by hormones. And then, as I mentioned earlier, I will go through kind of a pro-con debate about the risk of VTE with combined hormonal contraceptives. And then finally, we'll return back to the patient case to discuss a few of the issues that come up in our discussion. Let's begin by reading through this patient case. This is KB, who is a 20-year-old female in clinic today for a co-consult with the medical resident and the clinical pharmacist because she does not have normal periods. She has not had a normal period since she was 13 years old. She has moderate acne that she tries to cover with makeup, and she states that the hair growth on her upper lip has been growing thicker over the past few years, but she does get that waxed routinely. She has struggled with being overweight and finds it really difficult to lose weight. She has walked about 5 days per week for 20 minutes for the past 6 months and really has only been able to lose about 2 pounds. She smokes when she drinks, which is almost every weekend. Now, recently she has a new boyfriend, and they've been using condoms for STI, or sexually transmitted infection, and pregnancy prevention. The medical resident is asking you as the clinical pharmacist for a recommendation for a birth control pill to help her symptoms with her periods, acne, and hair growth, as well as provide more effective contraception. In thinking about this case, I have a couple reflective questions for you. First of all, which of the following hormonal contraceptives would you recommend for this patient? And I've given you a choice here of 5 different options. So first with A, would you choose an oral contraceptive that has ethinyl estradiol plus drospirenone, which would be something similar to Yaz or Yasmin? Or would you choose an oral contraceptive with ethinyl estradiol and desogestrel, which would be similar to Desigen? Option C is an intrauterine system, or an IUD, that has levonorgestrel only. That's Mirena. or maybe a progestin-only pill that is contains only norgestimate. And then lastly, we have the contraceptive patch, ethinyl estradiol, that was also containing norelgestromin. So of those 5 options, which would you choose? This really is just meant to be a self-reflective question. Then also we have a true-false question. I am concerned about a VTE in this patient. Would you say true or false? Now keep your responses in mind as we move forward with the presentation, and we'll be sure to come back to these questions. The discussion about how VTE occurs with contraceptives really must first begin with a discussion about the types of progestins in various contraceptives. We have 4 or 5 different generations of progestins, each with various androgen or estrogen activity. You can see that the first generation progestins, such as norethindrone acetate, or ethinyl diacetate, have higher androgen activity and lower estrogen activity. And what I'm really looking at there are the triangles at the bottom of the graph to indicate higher or lower estrogen or androgenic activity. As we move along the spectrum to the second, third, and fourth generation progestins, you can see that the androgen activity decreases. But in essence, we trade that for estrogen activity, which increases. Now, these differences could be clinically relevant depending upon the patient needs. For example, in our patient that we described in the case, we may want to choose a contraceptive that has less androgen activity because of her facial hair and acne. In these types of cases, we may choose contraceptives that have a third or a fourth generation progestin. So examples of third generation progestins are desogestrel or norgestimate. Etononorgestrel is the progestin used in the vaginal ring, and norelgestromin is found in the contraceptive patch. Another option for our patient may be a fourth generation progestin such as drospirenone. Dianogest is found in a newer contraceptive called Natasia and actually may be classified as a fifth generation progestin. Overall, you can see that those agents with less androgen activity are also agents that have higher estrogen activity. This is particularly important because we know that higher estrogen activity may lead to an increased risk in VTE. With that background information, I would like to now walk through several proposed mechanisms for VTE risk. And I'd really like to spend some time specifically talking about the first 2 bullets. As was alluded to in the last slide, total estrogenicity may really be an important factor. The total estrogenicity, which includes both the estrogen and the progestin components, kind of comprises that total estrogen effect. What we see here is that the progestin component selected can have a large play in that, and consequently then combined contraceptives containing the third or fourth generation progestins have a higher total estrogenicity as compared to the first or second generation progestins, which we've talked about earlier. And it may explain why users of these formulations, of the third and fourth generation formulations, are exposed to higher thrombotic risk. Now, ethinyl estradiol is the estrogen found in most combined contraceptives. Estradiol valerate is the estrogen found in Natasia, one of the newer contraceptives on the market. And that particular estrogen formulation has properties that may theoretically lower VTE risk, but that has not yet been shown. So given that you really are looking at the progestin and the estrogen components to comprise that total estrogenicity, and having that then puts us at a higher risk for VTE. Now, there are also the presence of risk factors, either genetic or acquired, that can affect proteins involved in hemostasis. Combined contraceptives can cause changes in coagulation that can attenuate the prothrombotic state that could be induced by pre-existing genetic conditions in kind of a synergistic way. And it may explain a higher rate of thrombosis, especially during the first year of use, when women who have maybe inherited defects or other risk factors may not be aware of it, and then they often experience a thrombotic complication shortly after they started using the contraceptive. So, for example, the time for women who are carriers of the factor Leiden mutations will almost, in about 50% of the cases, have a event within 2 years of starting that. Now, thrombosis can also occur because of other risk factors such as smoking, obesity, trauma, maybe immobilization, such as when people travel. And it's these synergistic effects of genetic and acquired risk factors that can lead to that considerable increase in the thrombosis potential. And it's essentially that puts those people in particular at risk. Now, there are some other factors that can come into play. Things like changes in coagulation, increased fibrinogen, prothrombin, coagulation factors, and decreased factor V. And these seem to be more pronounced for desogestrel containing or third generation contraceptives than levonorgestrel or second generation. There also can be changes in anticoagulation, enhancements in fibrolytic activity, and activated protein C resistance, all of which may be contributing to this proposed mechanism for VTE risk. Now that we have covered an in-depth explanation of the possible mechanisms for VTE with the use of combined contraceptives, let's take a look at whether or not there is an actual risk. We are going to start with a pro stance that there is an increased risk of VTE with combined contraceptives. When we take a look at the risk of VTE for combined contraceptives, we need to be able to look at the potential baseline risk. We can see that for CHC users, approximately 3 to 9 women per 10,000 women years will experience a VTE. What this means is that if 10,000 women were to take a combined contraceptive for 1 year, 3 to 9 of those women would have a VTE. For 10,000 women not taking combined contraceptives for 1 year and who are also not pregnant or not taking hormones, 1 to 5 of those 10,000 women would have a VTE. So you can see that the baseline risk of getting a VTE for any combined contraceptive user is going to be higher. However, the overall absolute risk or the actual risk of either one of them having a VTE is quite low. The absolute risk of a woman taking a contraceptive is actually less than 0.1%, and the absolute risk of a woman not taking a contraceptive is about 0.05%. So in summary, we really accept to some extent that there may be an increased risk of VTE in users of combined contraceptives, but that the overall risk remains very low. In April of 2012, a FDA Safety Communication was released regarding information about the risk of blood clots in women taking birth control pills containing drospirenone. It basically said that the FDA had completed a review of recent observational or epidemiologic studies and had concluded that drospirenone-containing birth control pills may be associated with a higher risk for blood clots than other progestin-containing pills. Specifically, they were requiring that drug labels be revised to report that there were some epidemiologic studies stating as high as a 3-fold increase in the risk of blood clots for drospirenone-containing products. Additionally, the FDA wanted to be able to report their summary findings of a study that they had also conducted. So what I would like to do now is walk you through a few of those epidemiologic studies as well as the FDA study looking at this increased risk. This slide essentially summarizes the epidemiologic studies that were evaluated, with the study and the citation being in the left-hand side column and the results in the right-hand column. Specifically for the results, it really lists the odds ratio, or the rate at which VTE could have occurred with a 95% confidence interval for VTE in drospirenone users versus levonorgestrel users. And what we find is that in the black results, those are essentially results where there was no difference between the groups. For those that are bolded in red, such as the trial by Lidegard, Parkin, Jick, etc., you can see that the red bolded numbers indicate a statistically significantly increased risk of VTE. So for example, if we look at the Lidegard study, what it tells us is that women taking drospirenone were 1.6 times more likely to experience a VTE than those taking levonorgestrel. And the parentheses indicate that 95% confidence interval. And when that confidence interval does not include one, that tells us that it's statistically significant. So when you look at these numbers of the significant findings, you can see that anywhere from approximately 1.5 to 3 times the risk was incurred for women taking drospirenone in those trials. Now overall, these trials are retrospective in nature, they're observational, and what that tells us when we look at this is that there's mixed data. There are some trials having no significant findings and other studies that have up to 3 times the increased risk. The FDA study that was evaluated looked at combined contraceptives and the risk of cardiovascular disease endpoints. And this was a retrospective cohort study evaluating data from 4 geographically diverse health plans. So they took 2 integrated medical care programs within Kaiser in Northern and Southern California and 2 state Medicaid programs, one in Tennessee and one in Washington State. And they looked at over 840,000 women, or around 840,000 women with about 900,000 person years. And they compared 3 preparations, specifically a preparation containing drospirenone, the vaginal ring, and the contraceptive patch. And they compared those preparations with 4 older combined contraceptives with similar low estrogen levels. The progestins in those agents were levonorgestrel, norathindrone acetate, and norgestimate. And so you're really getting a good comparison between newer preparations and older first or second generation progestin combined contraceptives. The primary outcomes they measured were atrial thrombotic events, VTE events, cardiovascular mortality, and total mortality. I'm going to be focusing on the VTE events in terms of talking to you about the results. When we look at the result of this study, we can see that in the left-hand column are the comparator contraceptives, drospirenone, norelgestromin, and etonogestrel, compared with all of the other agents that they were compared against, or just levonorgestrel alone. And you can see that in this particular study, drospirenone, the patch, and the vaginal ring all had a statistically significantly increased risk of VTE compared to the other comparators combined. And so with that, we can say that there's about a 1.5 to 1.7 increased risk compared to the other agents that were used. When we look specifically at new users, we can see that the drospirenone new users had statistically significantly increased VTE rates as well. Again, statistically significant by not including one in the confidence interval, and it's looking about anywhere from about 1.7 times an increased risk of having a VTE with those with that particular agent. Ultimately, after the FDA reviewed the epidemiologic studies as well as their own study, they decided to revise labels, prescription labels for drospirenone-containing products. This is an excerpt from the Bayes drug label, but would apply to any drug containing drospirenone. And I've highlighted for you in red the areas that I think are pertinent in the label change. Essentially saying that drospirenone-containing combined oral contraceptives may be associated with a higher risk of venous thromboembolism, and that the studies showed that that risk ranged from no increase to a 3-fold increase. And before initiating the use of a drospirenone-containing product, you really want to consider the risks and benefits of a drospirenone-containing combined oral contraceptive in light of her individual risk for a VTE. So risk factors that you may want to consider would include smoking, obesity, family history of VTE, in addition to any other factors that may contraindicate the use of combined oral contraceptives. Now, after all this information came out, the American College of Obstetrics and Gynecology, or ACOG, published a committee opinion paper late last year. It was in November of 2012, entitled Risk of Venous Thromboembolism Among Users of Drospirenone-Containing Oral Contraceptive Pills, Recommendations of ACOG. And essentially they looked at the recent reports, and standing in our pro stance, what they really conclude or state in that report is that data have suggested that the use of drospirenone-containing pills has a higher risk of venous thromboembolism. And they would argue that clinicians should really consider a woman's risk factors for venous thromboembolism and refer to the U.S. medical eligibility criteria for contraceptive use to determine whether or not it's an appropriate option for her. So for some of you that may not be familiar with this criteria, I'm going to briefly show you what that looks like for venous thromboembolism. The U.S. medical criteria for contraceptive use is available through the CDC website. It basically lists a variety of different conditions and the ability to use a particular contraceptive for that condition. Now, in this case, we're looking at categories for combined hormonal contraceptives, and in particular looking at the risk for DVT. Category 1 would indicate that there would be no contraindication, be acceptable to use that method with that particular condition. As you work your way through the categories 1, 2, 3, and 4, 4 brings us to those particular conditions where that method would be considered an absolute contraindication. So in this case, you're looking at a patient's history of DVT and whether or not they've been on anticoagulant therapy. You can see that it would be contraindicated in somebody not on anticoagulant therapy with a high risk for recurrence. Acute DVT or PE would be another contraindication. Even for people who are on anticoagulant therapy but remain at higher risk for recurrent DVT, that's considered a category 4. And then finally, women who've had major surgery and anticipate having prolonged mobilization, which of course puts them at a higher risk. So in those cases, a combined hormonal contraceptive would not be acceptable. It's considered a contraindication, and ACOG in those cases would then defer to this particular guideline for determining whether or not a particular combined hormonal contraceptive could or should be used. As you can see, most of the data thus far has really been focused on combined oral contraceptives. We have had some data with regards to the ring and the patch, but I think we also have to ask the question about potential VTE risk in users of non-oral hormonal contraception. And we do have one study that was recently published. It was a Denmark national registry that looked at women aged 15 to 49 years, and it was a population of about 1.6 million women. And they really compared outcomes of users versus non-users and looked at the rate of VTE for transdermal, vaginal, intrauterine, or sub-Q hormonal contraception, and then looked at the rate ratios of VTE in current users of non-oral products compared with standard reference oral contraceptives with levonorgestrel, which, as you know, is a second generation progestin, is kind of the standard against which other things are compared. Now, when we look at the results of this study, we're looking at the method in the far left column with the relative risk compared with non-users in the middle column, and then the incidence rate per 10,000 exposure years in the far right column. You can see here that there was a statistically significantly increased risk for the transdermal patch and vaginal ring compared with non-users. Additionally, we can see that the incidence rate per 10,000 exposure years is 7 to approximately 10, which quite honestly falls within that normal range that I mentioned earlier of 5 to 9 per 10,000 exposure years. And so what we're seeing there with compared to non-users is what we would expect with any combined hormonal contraceptive. Now what this does show us is that with sub-Q implants such as Implanon or the intrauterine device such as Mirena, that relative risk compared with non-users is not statistically different. And additionally, our incidence rates are very, very low. Now again, when we go down and compare it with users of levonorgestrel, we see a similar trend where we have statistically significant increases of VTE with the patches and the ring, and not with the implants and intrauterine device. And so when, again, we're looking at these numbers, I think what we can summarize from this is that, yes, there still may be that increased risk with these combined hormonal contraceptives, probably not as much with our progestin-only implants or IUDs. So when we summarize our pro stance in that VTE risk increases with combined hormonal contraceptives, we can say the following things, I think. We can say that third and fourth generation progestins may have more risk than second generation or first generation, that the use of drospirenone specifically is associated with an increased risk of VTE relative to the standard low-dose oral contraceptive pill, although data are somewhat conflicting for the vaginal ring and patch. New use of drospirenone also appears to have an increased risk of VTE, and that levonorgestrel, IUS or intrauterine system or the sub-Q implant may have the lowest VTE risk. And really decisions about contraceptives should take into account the overall risk of having a VTE, the patient preferences, and any available alternatives that may be there for that patient. Now that I've convinced you, hopefully, that there is an increased risk of VTE of combined contraceptives, let me take the con stance and see if I can convince you that there's not an increased risk of VTE with combined contraceptives. One of the reasons I would argue that there is not an increased risk of VTE with combined contraceptives is that our total estrogenicity has really significantly decreased since the combined oral contraceptive was first put into market. At that time in 1960, there was approximately 150 micrograms of ethinyl estradiol. Now, in today's market, we have 10 to 35 micrograms of ethinyl estradiol, which is significantly lower. And along with that, we've been able to also significantly reduce the risk of VTE over time. So when we went from 150 down to 50, we reduced it by about 17 to 32%. And now as we've gotten to formulations that are 20 micrograms or lower, we've reduced it by another 18%. Another thing to consider in this part of the equation is the pharmacokinetics comparison between the various options. In this graph on the y-axis, we have the ethinyl estradiol level, and on the x-axis, we have the days of administration throughout the month. In the red is a combined oral contraceptive, in black is the transdermal patch, and in blue is the vaginal ring. And what essentially this is showing us is the area under the curve in terms of what we would expect in terms of total estrogen exposure throughout the month. Obviously, looking at this graph, you can see that the lowest estrogen exposure would come from the vaginal ring. The oral contraceptive, while variable, with the highest peaks and lower troughs, actually still has a lower area under the curve than the transdermal patch, with the transdermal patch having the highest total estrogen throughout the month. And so this, in some ways, depending upon how you want to look at it, helps to for us to evaluate, again, that total estrogen piece, in that the vaginal ring may actually be lower than the oral contraceptive, which may be lower than the patch. In this slide, I'm showing you the exact same data as I showed you before. However, what I've done is now highlight those trials that are not statistically significant. And you can see that of these trials here, I've got 4 listed that show that there was no difference in the risk for VTE in people using drospirenone versus those using levonorgestrel contraceptives. Again, emphasizing the point that not only are the data conflicting, but there's equal data on the side saying that there is not an increased risk of drospirenone-containing contraceptives compared to those looking at levonorgestrel. When we look again at the ACOG committee opinion paper, we can see that when evaluating these drospirenone-containing pills, they're also stating that the risk is still very low, and in fact is much lower than the risk of venous thromboembolism during pregnancy and the immediate postpartum period. And so what they're saying is that patient education materials, including product labeling, should place all this information regarding oral contraceptive use and VTE risk in context. And I'm going to talk about that a little bit more, but really in this con stance, saying that while the risk is low to begin with, but it's actually much lower than the risk of someone when they're pregnant or in that immediate postpartum period. This is a study that was published just this year, looking at the recent use of combined hormonal contraceptives and VTE risk in new users. And what they did was look at all venous and atrial thrombotic events that were identified in 573,000 women aged 10 to 55 from 4 different healthcare programs. And what they did was evaluate new use of drospirenone, vaginal ring, and patch compared with 4 low-dose estrogen comparators. When we look at this data, we can see that drospirenone still had an increased risk of VTE that was statistically significant. However, we see in this particular study that the ring and the patch were not significantly different as it relates to VTE risk. And of course, none of these, as you can tell, affected total mortality. So we're seeing more consistency with an increased risk with drospirenone, less risk with other combined hormonal contraceptives. Now, just to be complete, I want to just briefly show you that there are also studies looking at the risk of VTE with the transdermal patch and comparing it to other low-dose alternatives. In this summary, you can see that there have been essentially 4 trials done, 3 of which have not shown a statistically significantly increased risk, 1 which has, and that was about a 2-fold increased risk. And so really looking at the total family of combined hormonal contraceptives, the transdermal patch overall doesn't appear that it has significantly increased risk, although theoretically with an increased estrogenicity, there may be more with the patch compared to some of our lower dose formulations. Let me show you now what I think is probably the clincher in terms of the argument for this con stance, in that there is not an increased risk of VTE with combined hormonal contraceptives. Here I'm showing you a graph that indicates the risk of developing a blood clot based on 10,000 women years. And I've already mentioned to you the 1 to 5 range for non-pregnant, non-users of combined hormonal contraceptives, the 3 to 9 range for those that are using. But when we look at the alternative risk of being pregnant or being postpartum, you can see that that risk really does increase. So in pregnancy, the risk of having a VTE is anywhere from 5 to 20 women out of 10,000 women years. When we go postpartum, up to about 12 weeks, it ranges anywhere from 40 to 65. So we're talking about dramatic impacts in terms of the risk of VTE when someone is pregnant or postpartum. Now, the risk of pregnancy without contraception in 1 year is about 85%. And so again, you're looking at balancing the risk and benefit of having a VTE for someone who's pregnant or not pregnant. Now, certainly if somebody wants to be pregnant and is desiring pregnancy, we take that risk into consideration. But for someone who may not want to be pregnant, this is something to consider in a non-pregnant versus pregnant patient. In addition to preventing pregnancy, there are many non-contraceptive benefits that contraceptives can offer, combined hormonal contraceptives can offer, such as treatment for acne, decreasing the risk of various cancers, treating hirsutism, helping endometriosis, cycle regulation, and dysmenorrhea. They're used in polycystic ovary syndrome, which our patient may have, as well as premenstrual dysphoric disorder. Now, the stars really indicate specific benefit where drospirenone may be especially helpful because of its progestin properties being anti-androgenic. And so we end up in this potential dilemma in choosing an agent based on other patient characteristics. To summarize the con stance, where VTE risk is not increased with combined hormonal contraceptives, then we can say that data are conflicting for many of the combined hormonal contraceptives. The risk of VTE while taking combined hormonal contraceptives is actually much lower than the risk of VTE while pregnant or especially while postpartum. And the last kind of point here is that CHCs really offer significant non-contraceptive benefits, which may ultimately, in the end, outweigh any risk for VTE. I've given you the pro and the con side of this argument, so let me just maybe summarize some of the major points in terms of VTE risk for contraception. We know that the mechanism by which VTE occurs with combined hormonal contraceptives is multifactorial, and we just want to really minimize risk when possible. There are conflicting data for various contraceptive options, and we really will need to be making patient-specific recommendations. And it's, from my perspective, the best ranking, so to speak, that I can give the combined hormonal, all hormonal contraceptives would be as follows. At the top of the graph or the chart here, I have those that would incur less risk of VTE. Those at the bottom of the chart would have more risk of VTE. So I think the lowest risk options are those that are progestin onlys, including the intrauterine system Mirena, the implant, and progestin-only contraceptives. Then that would be followed by second generation oral contraceptives, the vaginal ring, and then third generation oral contraceptives, the transdermal patch, and then finally the fourth generation oral contraceptives, which of those things that we've discussed would incur more risk comparatively. So hopefully that helps to summarize what I've been able to cover in this pro-con argument. Let's go back now to the patient case and the reflective questions that I asked towards the beginning of the presentation. So just to refresh your memory, this is a 20-year-old woman with abnormal periods, acne, hirsutism, and overweight. She exercises, smokes on the weekends, and has a new boyfriend. And I had asked you, which of the following hormonal contraceptives would you recommend? So now, after having what I've presented, would you recommend one of those two pills, the intrauterine system, the progestin-only pill, or the transdermal patch? And then the second question I asked you was true or false. I am concerned about a VTE in this patient. And just now thinking, what not only would you might choose or say, but how did that change from your initial guess or initial thoughts around this question? I'd like to just briefly go through my perspectives in dealing with this type of a patient case. So for this particular case, I probably would recommend a low androgen combined hormonal contraceptive. So a combined hormonal contraceptive that is in the third generation progestin. So it would be a low dose estrogen combined hormonal contraceptive with either desogestrel or nogestimate, or perhaps a vaginal ring, both of which I think have less risk than a drospirenone containing contraceptive, but all for which I believe would address her symptoms with the hirsutism, acne, and abnormal periods. I also, of course, would encourage smoking cessation and not to smoke on the weekends, to continue with the diet and exercise, and then add supportive therapies as needed. So maybe topical agents for acne, considering therapies for hirsutism, and so on. So that kind of hopefully gives you a good perspective on my views for this type of patient case with regards to VTE for contraception. I'd like to shift gears now and talk about VTE risk with hormone therapy. We've already discussed the mechanism. So in this part of the presentation, we'll go over a patient case. Again, we'll have a pro stance and a con stance, and then we will have a patient case discussion. Our patient case is a case about Mom, and she actually does resemble my mother when she was 57 years old. She has a history of smoking 1 pack a day for 35 years and pre-hypertension. She's been on ortho-prefest for 7 years. She previously took black cohosh, red clover, and rose hips for hot flashes, which were pretty severe at 12 to 15 per day, and night sweats 4 to 5 per night. She takes aspirin and a multivitamin. You can see her blood pressure, bone mineral density, and cholesterol overall look pretty good. Her father died of colon cancer at age 83. Her mom had a heart attack at age 89, and brother died of a heart attack at age 57. And the questions I have for you are, would you recommend continuation of hormone therapy? And secondly, are you concerned about VTE? And again, these are just questions for you to ask yourself and reflect upon in terms of kind of moving forward with this patient case. I will start again in the pro stance, arguing that there is an increased risk of VTE with hormone therapy. Probably the best place to start with this particular argument is the Women's Health Initiative. Most of you are probably very familiar with the Women's Health Initiative. It was a prospective randomized trial in over 16,000 healthy postmenopausal women aged 50 to 79 years. And they essentially evaluated Prem-Pro versus placebo for a planned duration of 8.5 years. Now, the primary efficacy outcome was coronary heart disease, because at that time we really believed that hormone therapy was beneficial for heart disease. The primary adverse outcome that they were going to be evaluating was invasive breast cancer. The WHI reported results for 7 outcomes and a global index. If we focus specifically at the risk of VTE, we can see that using hormone therapy incurred a risk which was approximately double that of those patients taking placebo. So that 2.11 tells us that women taking hormone therapy were twice as likely to have a VTE than those that didn't. Now, if we look at the actual numbers, 151 women out of 8,506 versus 67 out of 8,102, we can really see that, yes, indeed, there is an increased risk with the hormone therapy group. Now, I'd also like to point out that the annualized percentage, or the actual percentage of women that would have an event in 1 year, is 0.34% for those taking hormone therapy and 0.16% for those taking placebo. So again, that overall risk being very low, accepting the fact that women taking hormone therapy will have a higher risk than no therapy at all. Now we can put that risk of VTE into more absolute numbers as well. When we look at this, we can see that out of 10,000 women treated for 1 year, 34 of them would have a VTE if they were taking hormone therapy. 16 of them would have a VTE if they were taking placebo, with an absolute difference of 18 between the groups. Now, if we look at the number needed to harm or treat in some cases, in this case it's harm, based on treatment for 1 year, if we treated 556 women, one of them would likely have a VTE. And so we're really looking at potentially harming someone with a VTE before we prevent anything that might be good, like a hip fracture, for example. Now, when the WHI was published, there were several issues that came up specifically regarding the regimen that was used, in that people argued that only one hormone therapy regimen was tested, specifically being Prempro, and that these results may or may not apply to other doses, forms, or routes of estrogen, other doses, forms, or routes of progesterone, and also younger women in menopause. Since then, we've had some data to help explain and expand some of this knowledge. Let's take a look. The Million Women study is a study that has evaluated postmenopausal women using different formulations of hormone therapy. This study looked at over 1 million postmenopausal women in the UK, and data were collected through the National Health Service. They looked at hormone therapy use and the risk of VTE using a Cox regression analysis, and included over 3.3 million years of follow-up. Now, what they found was that 2,200 women had a VTE. Keep in mind, this is 2,200 out of over 1 million women, which gives us a rate of about 0.2%. They were diagnosed on average about 1.5 years after their last hormone therapy use. And when they looked at current versus never users by formulation, you can see what they found. The relative risk for oral hormone therapy was approximately double for current users versus never users, statistically significant. For oral estrogen only, it was about 1.4 times greater for current versus never users. Now, interestingly, there was no statistically significant difference with users of the transdermal estrogen patch. And so we have thought theoretically and in previous trials that may be the case, where VTE is less likely with the transdermal formulation, and here it did play out. Now, interestingly, were also increased risks involved with the progestogen that was chosen. So that for medroxyprogesterone preparations, there was a 2.67 times increased risk, and for other progestin preparations, almost a twofold increased risk, which were in both cases statistically significant. This study also went on to evaluate the type of estrogen and progestogen that was used in the hormone therapy. For example, when looking at the estrogen constituents and dosing, we saw a statistically significantly increased risk for both equine estrogen, which we find in products like Premarin, and estradiol, which we find in products like Estrace. And it didn't seem to matter if a low or a higher dose was used. We still saw increased risk. There was also twice the risk of VTE in the first 2 years of initiation. And similar to the contraceptive, maybe earlier initiation incurs higher risk. In over 5 years, they also looked at hospital admissions or mortality from pulmonary embolism. And we see that it was 1 in 660 of never users of HT. but then anywhere from 1 in 250 to 1 in 475 for users of hormone therapy, with risk increasing when you have users of hormone therapy containing medroxyprogesterone acetate. Lastly, I wanted to show you some data from a Cochrane review that was recently published on long-term hormone therapy for postmenopausal women. And they combined data from 23 studies involving over 42,000 women, but keep in mind that 70% of them came from the WHI and the HERS trial. And the mean age in these studies was over 60 years of age, which we wouldn't typically use hormone therapy in that patient population, but really just to demonstrate the risk of VTE that can occur, especially for those with continuous hormone therapy, that meaning taken everyday estrogen and progestogen therapy. The risk of VTE after 1 year is 7 per 1,000. So now we're not talking about 10,000 anymore, we're talking per 1,000. And if you look at the outcome for the estrogen only, we can see that there's a VTE risk after 1 to 2 years of 5 per 1,000, and with long-term use after 7 years, 21 per 1,000. So that there is evidence here that there are increased risks for VTE with hormone therapy. Let's move now to the con stance, where I'm going to create an argument that there is not an increased risk of VTE with hormone therapy. Perhaps the most important reason there is not an increased risk of VTE with hormone therapy is that there is such a thing as the hot flash. Many women would argue that the hot flash is extremely uncomfortable and at almost any risk would be wishing to have relief. And we know that estrogens are the most effective treatment for hot flashes with an 80 to 90% reduction in symptoms. The Kronos Early Estrogen Prevention Study, or KEEP study, is a study that's recently been conducted and initial results have been published in abstract form. This was a study involving 727 women aged 42 to 59 with a mean age of 52. So these women were relatively new to menopause. And they were randomized to a lower dose of Premarin, 0.45, as an oral conjugated estrogen, 50 micrograms of Climera estradiol patch, or placebo for 4 years. Women on estrogen also received 200 milligrams of micronized progesterone, or permetrium, at least for 12 days per month. Now, the results when compared to placebo showed us, as we would expect, that hormone therapy reduced symptoms of menopause and had favorable effects on BMD. We also saw that hormone therapy had improvements in sexual function, lubrication, decreased pain, and additionally, transdermal therapy had improved arousal and desire. Cardiovascular progression was not as concerning. The oral formulations increased HDL and decreased LDL, as we would have expected, as well as increasing triglycerides and CRP levels. So one of the biggest findings from this particular study is that there was no significant differences in the rates of breast cancer, endometrial cancer, MI, TIA, stroke, or VTE between these three groups. Now, it could be that it's a lower number of women in this study, just over 700. It could be that we use lower doses. It could be that the transdermal formulation was involved. But at this point, with these preliminary results, we can at least say maybe for this newer menopausal age women that risk of VTE with these lower doses and or the transdermal formulation with the micronized progesterone may have potential for a reduced risk of VTE. So now with the pro and con stance presented, let me summarize the VTE risk with hormone therapy. First of all, I just want to emphasize that hormone therapy is not indicated for primary or secondary prevention of coronary heart disease. Secondly, data support the initiation of hormone therapy around the time of menopause to treat menopause-related symptoms, and that would be the primary reason we would want to be using hormone therapy. The current use of oral hormone therapy in postmenopausal women increases the risk of VTE approximately twofold. We've known that for quite some time. That's often been a risk that we have accepted. And so that piece of data isn't necessarily new. It's just that we're putting it now in probably a more appropriate context with a proper age. Keep in mind, too, that the risk of VTE may vary by formulation, in that the transdermal appears to be somewhat safer than oral, and the micronized progesterone or progestins appear safer than medroxyprogesterone acetate. So if you have a patient with high risk of VTE, you may want to consider these formulations rather than other oral formulations. As we now go back to the patient case, think back to what you thought in your own mind about continuing hormone therapy in this patient and whether or not you were concerned about a VTE in this patient. We know that estrogen would be the most effective therapy for her hot flashes and night sweats, but the patient's now 57 years old and has been on this therapy for 7 years. If therapy were to be continued, I might want to consider a transdermal formulation with a micronized progesterone if we decided to continue that, but really try to minimize use in patients up to 5 years. And that just goes based on trials that have been conducted up to this point. I would, in this patient, particularly would want to consider other options for hot flashes, particularly to taper and discontinue the hormone therapy if we could and use non-pharmacologic measures, things like dressing in layers, keeping water nearby, exercising, stress relief, things like that. And if needed, to consider antidepressants like an SNRI such as venlafaxine or the SSRIs, fluoxetine and paroxetine. All of these antidepressants give us approximately 50 to 60% reduction in hot flashes. Gabapentin has also been evaluated and has an efficacy rate of about a 50% reduction in hot flashes as well. We've covered a lot of information in this presentation, so I want to just conclude by giving some general summary statements about VTE risk for both contraception and hormone therapy. We know that VTE risk is due to both estrogen and the progestogen contributions, and hopefully in both contraception and hormone therapy, you've been able to see how that comes into play. We really need to make sure we're evaluating VTE risk for individual patients to determine which therapy may be best for them. That includes acquired risk, smoking, obesity, personal and family history, as well as genetic contributory factors. Studies can always be improved. We hope that we will get more, and we really need to make sure we discuss the risks versus benefits and tailor recommendations to individual patients. You can see that you can argue both sides of this and that there are risks, there aren't risks, and it really depends upon that individual patient. And overall, we want to make sure we're educating patients to minimize the risk and monitor for signs and symptoms of VTE.